Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about value-based care and value-based payment. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability. I'm trying a new format today. I've always enjoyed using slides. I think it will bring more clarity to my answers. Let me know what you think.
Yeah, we absolutely want to hear your feedback on the new format and any future questions you might have for Dr. Mingle. Remember, you can send us a question via a YouTube comment or a LinkedIn comment, or you can send us an email at hello@minglehealth.com. So in today's episode, Dr. Mingle, you're doing some myth busting. You're covering eCQMs and the APM Performance Pathway, that is the APP, for MSSP ACOs. So take it away.
Thanks, Kyle. That's a big and important topic for our friends participating in the Medicare Shared Savings Program. So let's dig right in. Listed on this slide are the four myths we generally run into in one way or another. Let's run through the four of them with a short answer on each, then I'll dig into each of them individually with a little more detail. Now, to be sure we're all on the same page, I'll briefly describe the Medicare's web interface quality measurement tool. It provides an estimate of quality, unlike the quality measurement intended for other programs. It's based on a random sampling of patient charts in the organization and usually done with manual chart abstractions. It was introduced first in 2012 in support of the first trials of Medicare's accountable care organization models and to provide the quality reporting for the Physician Quality Reporting System, or PQRS. It was expanded in 2013 to meet the needs of group practices participating in the new group practice reporting option, or GPRO of the PQRS system. In 2017, it was carried over into the Quality Payment Program in support of Medicare Shared Savings Program, and to continue supporting large practices, 25 or more providers in the MIPS program. In 2021, new rules were introduced to sunset the web interface and to switch the MSSP or all alternative payment model, provide an option for all alternative payment models of a new measurement system, the APM Performance Pathway, called APP. And the initial options for the APP were the Medicare web interface, MIPS CQMs, and eCQMs. In 2024, Medicare CQMs were added as a temporary method for reporting the APP. And finally, in 2025, after the 2024 quality measurements were calculated and submitted, the web interface did in fact sunset. Now those people who are using the APP, the Alternative Payment Model Performance Pathway, can choose eCQMs, MIPS CQMs, or Medicare CQMs. With MIPS CQMs scheduled to sunset after the 2026 reporting performance year reporting. So the first myth, we've got to change to eCQMs by the 2027 performance year. Well, MIPS CQMs are in fact set in the rules to sunset after the 2026 quality submissions are in. But it's important to note that any Medicare rule can change in one annual rulemaking cycle, and there's two ahead of us between this date and the scheduled sunset of MIPS CQMs. Second, Medicare CQMs are still an option, so you don't have to go to eCQMs, although admittedly Medicare CQMs though easier to collect the data and calculate because it's a smaller number of patients. You can conceivably abstract the charts for those submissions. It requires a higher score to meet your performance standards to collect shared savings. So it's not a great choice. The biggest thing is that until the year actually gets here and or at least the last final rule for 2027 is published, MIPS eCQMs can be revived. And I think it should be, and I think you should take opportunity to comment on that if you agree with me in the rulemaking cycles we're facing between now and then. It's a great idea for all practices to be all electronic. Get there if you can, when you can. Electronic reporting brings with it efficiency and utility. When everything's set up and functioning well, it gives you your proof of quality for the value-based payment programs. It can generate reminders for patients and providers to get critical things done. It tracks your improvement efforts to know when it's working, those things that you're trying. eCQMs, MIPS CQMs, Medicare CQMs, they can all be used all electronic. You don't need to go to eCQMs to be all electronic. And eCQMs are not trivial. They can be expensive. They can be difficult. In ACOs, they're also fragile. There may be a target practice you have to bring in to serve your population. That any practice you bring into your ACO can screw up your electronic reporting. Take you back to the beginning to re-engineer it. In contrast, MIPS CQMs are flexible and inclusive. You can use any type of data that's accurate to build your MIPS CQMs. It's a bad idea to force eCQMs, to push them before it's time. In typical use, MIPS CQMs compared to eCQMs are more accurate, are less expensive, are more flexible and usable. There's no healthcare organization more complex than an ACO. If you're having trouble in other healthcare organizations, ACOs are certainly going to have trouble. It's the wrong place to bring this first. There are two primary outcomes that mark value-based care. Only two that are important. It's quality and cost. If you have a practice who can provide and prove they have great quality, and Medicare has all the proof you need, who is providing low cost, that is value-based care. At best, the use of certified electronic health record technology is a process measure. We don't care about the process measures as much as we do those primary outcomes of cost and quality. If you have someone who's just nailing it with cost and quality, they should be rewarded. They should not be penalized for not using certified electronic health record technology. Comment to Medicare when you have a chance. You'll have several chances between now and the projected sunset date of MIPS CQMs in the APP. Medicare listens. Make sure they get your message. Myth number 2, we have to invest in QRDA1 or FHIR HL7 files from all of our practices in order to do eCQMs. Well, no, that isn't necessary. Those are the standard file types you find in quality reporting in the creation of eCQMs, but they're only required for certification. Your vendor needs to be able to read them and write them in order to be certified. But when it comes to operationalizing your quality reporting program, your vendor can use any file that's generated fully electronic. You're not permitted to do manual chart abstractions as part of an eCQM production. All electronic. They have the ability to translate from whatever you have into the standard formats. They should be able to translate between the standard formats, but if you don't have them, they don't need them. Accurate, compatible, HL7 files are rarely achievable from all members of the typical ACO. Myth number 3, my EHR vendor can't do this. How can Mingle Health do it? Well, at issue is the business model and core competency. You wouldn't go to a restaurant to get the oil changed in your car. They can't handle it. No matter how good a restaurant they are, they're never going to be able to do it. Now, your EHR vendor is very good at what they do. Their job is to ease the burden of data entry at the point of care. They need to keep your data secure and accessible in long-term storage. And there needs to be efficient, effective data access whenever or wherever you need it. And it takes 2 years for a great new idea to get into the typical EHR. Their purpose is that reliable platform that's always usable, always available. You don't have to keep relearning new tools to use it. It's just there and reliable. And they're not in the business of enabling their competitors. They don't care about their competitors. They want everyone to buy their models. Now, Mingle Health was designed to help practices get data out of their EHRs, no matter what it is. Any practice, any specialty, any size, any health record system, even paper systems, and we're designed to adjust and change as quickly and frequently as Medicare changes the rule. It's just our business model. We started in PQRS. We never imagined this APP process being coming live, but the process that we've been doing throughout the whole PQRS and QPP systems, it's perfectly suited to doing the APP for you. We don't have to redesign. We don't have to rebuild. Everything we've done for years is functional and helps you to get your required reporting out of whatever EHR or mix of EHRs you are using. That brings us to the 4th myth. A lot of our prospects tell us they'd love to run parallel processes for MIPS and eCQMs until they can transition fully to eCQMs. It's not prohibitively expensive in our hands. Now, we recognize that every practice is unique in their choice of EHR, their configuration choices, and their documentation workflows. We've been anticipating that. We've been working with that for the last 15 years. Now, we have one broadly applicable and highly flexible process to exploit your strengths, accommodate your weaknesses, and give you choice. We've built this flow sheet to show you what we mean. Now, over here, this first column represents your ACO. It's made up of practices. Every practices have their own record-keeping system. They rarely talk to one another. They're rarely compatible with one another, even if they're different instances of the same EHR. There can be paper records in those. Now, out of those records, everyone can create something, and that's in this column here. We can look for QRDAs, FHIR. You've heard the terms Transact SQL, flat files. Sometimes they generate their own reports. They have a reporting mechanism in them. They can generate 837 claims files as part of the billing process. You can always manually extract from paper charts or EHRs. Now, we take all that data in our analytics engine. We deduplicate it. We cross-identify from system to system. We apply the specifications, the appropriate specifications, whether they're Medicare CQMs, MIPS CQMs, or eCQMs for the measures you're looking to submit. We identify denominators, we identify numerators, we resolve conflicts when different practices report different performance metrics for the same patient. We aggregate and we display. That happens in every complex organization we work with. Even the simple ones, it happens much more easily from our standpoint. You see that data and you can adjust based on the output. with the intention the foundational intention typically to produce a MIPS CQM, that's this center line here. We may be able to produce a MIPS CQM that meets your needs. If you require a lot of chart abstraction, it may be an advantage to flip the switch, eliminate all the patients who aren't Medicare Part B, and output Medicare CQMs. So for us, it's as easy, and for you, it's as easy as flipping the switch. Eliminate the non-Medicare patients, and you have Medicare CQMs built with MIPS CQM or Medicare CQM specifications, which are identical except for the insurers included in those outputs. On the other hand, if you're working toward eCQMs, most ACOs are generating a mix of abstracted paper charts and electronic submissions. Once your manually abstracted volume falls within your allowance for data completion, we can turn off the manual data and submit your electronic data as an eCQM using, of course, the eCQM specs. So what you're building from the very first is going to build that ultimate EHR eCQM submission. If you're effectively pushing the envelope and getting more electronic data year by year out of your practices, you may already be there. But with us, you will have that choice to go MIPS CQMs, Medicare CQMs if you have to do a lot of chart abstractions, or eCQMs if you have few enough practices doing manual abstractions that you can absorb them in your data completeness allowance. This is how we see things, and I hope my explanations have been helpful to you, help make you more calm about these choices in front of you, convince you at least to give us a try, give us a call, let us show you, talk more specifically about what we can do to relieve your distress, to solve your specific and unique problems. This is what we do. This is what we love to do. This is why we're in business, and we'd like to help you get there. Thanks for joining us on this episode of Ask Dr. Mingle. Please ask your questions, correct my answers, contribute your comments. We are smarter together. See you next time.